Good morning, everyone. Welcome to this session. So just to explain the format of this session, so we'll have Professor Sally Singh speaking to us initially, and then we'll move into our rapid fire presentations. After Sally has spoken, we will have time for Q&A with her, and then we'll save all the questions from the rapid fire till the end of the rapid fire. Okay, so first of all, can I welcome Sally? Sally is a Professor of Pulmonary and Cardiac Rehabilitation at the University of Leicester. She is Head of Pulmonary and Cardiac Rehab at the University Hospital of Leicester NHS Trust, and she's the Director of the Centre for Exercise and Rehab Science, which is a multidisciplinary group of researchers conducting a range of research projects in the field of exercise and rehabilitation. And Sally is also an NIHR Senior Investigator. Sally's here to talk to us about the personalised exercise rehabilitation for people with multiple long-term conditions PERFORM trial. So please give Sally a warm welcome.
Thank you very much for that welcome, and it's a pleasure to be here to talk to you about the PERFORM trial. So this is what I plan to cover in the next 10 to 12 minutes to allow us time for questions. A quick overview of what is multimorbidity, the importance of exercise-based rehabilitation, which of course as a group of physiotherapists is really important to us, and then to talk to you about the PERFORM trial, which is an NIHR-funded programme grant to the tune of £2.5 million, so quite a lot of work to do over the next few years. So just to remind you all what multimorbidity is, although hopefully you won't need any reminding, it's the coexistence of two or more chronic diseases. And it's a problem that begins early in life, but obviously accumulates as people get older. There's been a slight nuance to the definition from NICE and the Academy of Medical Science that suggests it should be a combination of one physical long-term condition and one mental health condition, which does present some challenges potentially in terms of trial recruitment. So we've taken the definition of two or more coexisting long-term conditions. Now, multiple long-term conditions is a growing problem for the individual and society, and this graph simply shows you the increasing burden with deprivation, ethnicity, age, and shows you that actually the more deprived you are, the earlier you tend to accumulate long-term conditions. So in terms of addressing health inequalities, multimorbidity is a really important component of that. And as many of you look forward to working in 2035, which I hope I won't be, clearly it's going to be a big challenge for many of you because a vast proportion of your population will be multimorbid. So we know that rehabilitation is clearly a priority for us as physiotherapists, but it's also now risen the ranks within the World Health Organization. They have a document that suggests that everybody should have access to rehabilitation by 2030. And last year, they published packages of information to help people globally deliver rehabilitation. And I was fortunate enough to help with the one around pulmonary rehabilitation, but they also address cardiac rehabilitation, MSK, and neurological conditions as well. So it is globally on everybody's agenda. Now, in the UK, we have predominantly, in terms of structured rehabilitation programs, they tend to be either pulmonary or cardiac rehabilitation. And we have in excess of 200 pulmonary rehabilitation programs, 200 cardiac rehabilitation programs, and of course, some structured programs for MSK problems. And there's a wealth of information and guidance on how we should deliver that. The British Thoracic Society, the British Association of Cardiac Rehabilitation, and NICE recently revisited the guidance on arthritis and suggested that supervised exercise would be important. So the overarching assumptions of our PERFORM trial is that multimorbidity is a significant and growing problem. There's evidence for exercise-based therapy in many single long-term conditions, So most of the evidence that we have all looked at traditionally as physios has been in a silo with a single long-term condition. But there are many long-term conditions that, despite the fact there may be evidence that exercise is valued, they don't have access. And in my world, people with peripheral vascular disease would be a good example, people with chronic renal disease, etc., and post-stroke or post-TIA. And from a commissioning point of view, there is absolutely a limited appetite to develop replicate services that are structurally the same. There is no appetite or funding to do that. So we have to look at different models and different workforce skill sets to deliver a more complex, comprehensive intervention. So this is the work package that we've committed to for our £2.5 million. And work package 1 was very specific around identifying the appropriate population that would benefit from exercise-based rehabilitation. Many studies that have looked at multiple long-term conditions as their population have been unselective and have largely failed. So Cochrane reviews around interventions for people with MLTCs are broadly negative. And I would suggest that's because they've not selected the population appropriately. So we've set about identifying the correct population. We've done that with looking at big data sets, so biobank data, sale data, and then done a review of reviews to make sure that we are selecting the right population that benefit in terms of exercise interventions. Work package 2 was an intervention development phase led by people that have absolute skills in intervention development and behavioural psychology, so that's not me. And work package 3 was a feasibility randomised controlled trial that we have now completed. So we are now at the stage of going into work package 4, which is a fully powered randomised controlled trial with an embedded trial looking at the impact of social media. Now, the expertise in social media actually comes from Manchester, and we're looking at the value of using Facebook in terms of retaining people within the context of a clinical trial. That's irrespective of their condition. This is just a concept of can we use social media to help retain people in trials. So this is the first piece of work we did, where we did a review of reviews looking at all of the long-term conditions that might benefit from exercise and therefore be in our inclusion criteria. On the graph, you can see the diseases that are represented as circles. So this is a bubble plot that identifies the number of participants and then the effect. So on the right-hand side, we have single long-term conditions where there is a large body of evidence, both in terms of the effect size and the population. And you can see there's really no big surprises there. We've got painful conditions, chronic heart disease, cancers, musculoskeletal, CKD, COPD, and buried in there is also long COVID. So there's an emerging evidence base for exercise in a long COVID population. On the left-hand side, we have diseases for which there is no evidence or we're unsure of the evidence. So that population will not be included in our trial. And this is what the PERFORM intervention looks like for those of you that are involved in pulmonary or cardiac rehabilitation or the escape pain packages. It will be very familiar to you. So it's a structured exercise program that has individually prescribed and progressed aerobic exercise training with a strength training component that is top and tailed by a comprehensive assessment to set that training load, identify psychological disturbances, etc. And the exercise training is accompanied by sessions to address issues around health and well-being. And then we plan to have maintenance sessions at the end of that. So we've just completed the feasibility trial, testing this and the acceptability. And of course, family and friends are more than welcome to attend the sessions as well. So this is what the health and wellbeing sessions look like. You can see they're very generic. For those of you that work in pulmonary or cardiac rehab, you can see some commonalities, but there are some more generic issues. We don't tend to address sleep or pain in pulmonary rehabilitation. So we have been much broader in terms of addressing the symptom burden of people with multiple long-term conditions. And of course, this was absolutely guided not only by providers like you, but also by patients and carers that experience multiple long-term conditions. So this is the rather complicated trial design. So we have a randomized controlled trial with this sub-study in looking at social media, and I'm not really very happy to take any questions on that. And then because people are routinely offered pulmonary or cardiac rehab, it would be considered unethical to randomize that population. So we have a prospective cohort trial where people with pulmonary or cardiac conditions will be invited to take part in the PERFORM intervention rather than their standard cardiac or pulmonary rehabilitation, and we will use national audit data sets to benchmark the effectiveness of PERFORM against nationally provided pulmonary and cardiac rehab to make sure people aren't losing out by undergoing this more generic multiple long-term conditions intervention. So in summary, we all know that multiple long-term conditions present a huge burden, of course, to the individual, but also to us as healthcare providers and the NHS and society in terms of people's employability. We know it's a challenge for physiotherapy. When I look at the list for people that come to pulmonary rehab, of course, they have an index condition of COPD, asthma, bronchiectasis, but they have a whole raft of other diseases that we sort of tend to park broadly and try and address more their breathing problems. So I think it is a challenge for us. We all know that the current NHS is absolutely siloed. And I think that PERFORM is an opportunity to develop a disease-agnostic approach to managing multiple long-term conditions, which physiotherapists should lead. And if anybody's interested in being a site, I absolutely, at the last minute, on the advice of one of the other people presenting today, have added my email address. So anybody's got any interest, please do email me. Thank you.
Hello. I was just wondering about working sort of with the mental health population who often come with kind of mental health issues but have a lot of long-term sort of comorbidities.
Yeah, so we, you probably won't remember, but on the bubble plot, we had people that had mental health conditions. Sorry, I can't see where the question's coming from. So we will absolutely accept people that have mental health conditions because they are falling within our inclusion criteria. The exclusion would be for somebody that had such severe behavioural problems that taking part in a group activity would be quite challenging. So that I suspect is the same for many other interventions, but we will absolutely include people that have documented mental health conditions. And of course, psychological well-being across the board is one of our important outcome measures.
Hi, thank you. Sally, sorry if I missed this at the start. Would you be able to confirm something about the sites? Because my understanding is that sites could be in the community or primary care as well as in secondary care.
No, you're absolutely right, Ruth. So we've tried to look at a spread of sites so that obviously when anybody does a trial, particularly those funded by the NIHR, they have an eye to implementation, so that trials aren't treated as an academic exercise, but there is follow through in terms of commissioning and offering of services to patients with multiple long-term conditions. So we have been, in our feasibility trial, we had a community site and 2 acute trusts, and we actually recruited remarkably, for any of you involved in trials, we recruited ahead of schedule, which is almost unheard of these days, because I think there's such an appetite to have something to offer people with multiple long-term conditions. But going forwards for our 20 sites, we've been very clear that we want a mix of community and hospital sites to support that implementation phase. What we have drawn a line with, and we've discussed this with our advisory group, is that we would expect a healthcare professional to be in the room. Now that ideally, obviously, within these 4 walls would be a physiotherapist, but that isn't always possible. But it would be a healthcare professional with experience in managing exercise behaviours in people with long-term conditions.
Thank you. That's a real shout out for community and primary care.
Yeah, no, absolutely. Yeah, because if there was a GP in the room, they would absolutely say that's where, you know, the hub is for managing long-term conditions. Once they get into secondary care, it's absolutely siloed. So we are looking at primary care sites very actively to provide the test intervention. I'm just going to go down this way.
Okay, now we're going to move into our rapid fire programme. So our first speaker is Charlotte Nichol from Northumbria University.
Yeah, so I'm Charlotte Nichol from Northumbria University, and we did a qualitative study that looked at the barriers and facilitators of uptake of cardiac rehabilitation in octogenarians. So cardiac rehabilitation, obviously everyone knows, can improve outcomes after a cardiac procedure, but quite often older octogenarians, they're excluded from the data because they're either considered too frail or they're just not suitable for inclusion. But they are actually the people that could benefit the most because it can reduce their risks of falls and rehospitalizations, which they have a higher risk of after a cardiac procedure. So currently, cardiac rehabilitation uptake is limited to 52%, with national variability, with lower uptake rates in areas of economic deprivation. But the NHS has a long-term plan of increasing that to 85%. So what we did was we did a qualitative study with semi-structured interviews of 20 participants from a large NHS trust. These patients either had transcatheter aortic valve implantation, surgical aortic valve replacement, or angioplasty, and they all had to be over the age of 80 years, as this is the group that is often excluded from the data. So from that, we found 3 key themes, and the first one was perceptions and understanding. So we found that what patients understood about cardiac rehabilitation influenced whether they would take up cardiac rehabilitation programs after their procedure. So quite often they thought that the procedure they'd had was the cardiac rehabilitation and that they wouldn't need anything further. And after they'd had that procedure, they would return back to normal straight away. So they thought like that's been and done. But patients that understood what cardiac rehabilitation was believed that they were actually too old to take part, and that's because all the data on cardiac rehabilitation programs is for younger people. So they believe that they wouldn't actually be suitable for the programs. Then the second theme was delivery and accessibility. So we found that the location of where cardiac rehabilitation programs were would impact whether participants would take the programs up. So a lot of the participants we spoke to were either from rural communities or had to travel quite far to get to the hospital for their procedure. So they believe that if they had to travel that far for a cardiac rehabilitation program, they wouldn't take part because it was just too much of a hassle for them to get there. And especially if it was on a weekly basis, they just didn't see that as being feasible. So participants did actually say that they would be happy to take part if it was either in the community because that's more accessible for them, or they would be quite happy to do an at-home program with iPads, YouTube videos, one-to-one support online, because they could fit it into their timetable and their schedule without having to go out of their way for programs. And then the final one was perceived impact of exercise and health life changes. So if participants had a busy life, they didn't want to take part in cardiac rehabilitation programs because it would impact too much on their prior commitments, and if they had comorbidities, they'd be too fearful of it. And then we found that there were many factors that can impact cardiac rehabilitation programs, and we're actually using these findings to inform a future study that is developing an intervention for octogenarians after their procedure.
Thank you, Charlotte. Okay, can we have our next speaker, who is Laura McGarrigle, and she's from Manchester University Hospitals NHS Trust.
Hi, my name's Laura. I'm going to present to you a systematic review that I completed as part of my pre-doctoral NIHR fellowship. So I'm sure you're all familiar with frailty. It's a bit of a buzzword, isn't it, at the moment? But if we define frailty as a lack of physiological reserve and an increased vulnerability to stresses, particularly infection and surgery, we know that frailty is common in end-stage lung disease, and it's linked to adverse outcomes for patients on a lung transplant waiting list. It is linked to increased mortality on the waiting list and an increased risk of being delisted. We know that exercise has been shown to be beneficial at improving exercise capacity and quality of life in these patients, but we don't yet know its full impact on frailty. So we set about performing a systematic review to evaluate the effectiveness of exercise on physical frailty in adults awaiting a lung transplant. So we wrote our protocol, which we prospectively registered on Prospero and we published within BMJ Open. We systematically searched 4 databases from 1980 to the 2024. So we started with 1980 because this is the date that cyclosporin, the main immunosuppression drug, became usable and therefore feasible lung transplantation could occur. We performed abstract and full text screening by 2 independent reviewers, and we piloted and used a data extraction form which was checked by a second reviewer. We performed study quality assessment using the NIHA tool for pre and post studies without control groups, and we performed a grade assessment of the certainty of findings by outcome. We weren't able to perform a meta-analysis because of the heterogeneity of interventions and outcomes. So we identified 15 articles that met our inclusion criteria, 13 of which were pre and post designs, and including 664 patients overall. The main interventions were pulmonary rehab, which included in-person, group and one-to-one, and synchronous and asynchronous app and telehealth programs. The exercises were mainly included aerobic, resistance, balance, flexibility and breathing training. We discovered that only 2 of the studies used a phenotypic frailty outcome. The majority were using surrogate frailty outcomes, including the short physical performance battery, 5 times sit-to-stand test, gait speed, hand grip or other muscle strength testing. Most studies were retrospective and uncontrolled, and only 1 study actually targeted frailty with the interventions that they used. So there were a wide range of frailty scores and surrogates that we used, but what we found was that exercise appeared to be safe, and it demonstrated improvements in some markers, but particularly the short physical performance battery, 5 sit-to-stand scores and gait speed. The studies demonstrated poor to fair methodological quality because of lack of blinding and inadequate sample size, and evidence was very low to low certainty for all outcomes due to risk of bias, inconsistency and imprecision. And this therefore limits the conclusions we can draw about the effectiveness of these interventions. So our review demonstrated that despite some evidence of the effects of in-person and remote digital aerobic and strength training on physical frailty outcomes in this lung transplant candidate population, the current evidence is limited because of the uncontrolled pre-post designs used and the low to very low certainty across outcomes. And without clear evidence of the optimal setting, the content, and we just don't have the clinical guidelines that we need for this population. So future work, we need well-powered RCTs, I feel like everybody says that in their conclusion, don't they, to evaluate the optimal setting, the optimal content and the delivery of interventions specifically to target frailty before a lung transplant, and therefore allow us to provide some exercise clinical guidelines for lung transplant candidates. But we also need a better understanding of how we can engage patients, the feasibility, and particularly within the UK context where prehabilitation under transplant services isn't routine practice. So we need a much better understanding of what these patients find acceptable, what they're going to adhere to, and how we can ultimately optimise our post-transplant outcomes. Thank you very much.
Thank you, Laura. Okay, so our next speaker is Jane Simpson from Whittington Health NHS Trust.
So I'm here to talk about the impact of collaborating with voluntary and charitable sector if you want to hear the voices of marginalised groups. I'd like to thank the CSP for inviting me to share this work, but also to thank Ellen Duckers there, who's the physiotherapist from the Camden service, which is the pulmonary rehab service that we carried this work out with. So what we were doing was part of the NHS strategy to address health inequalities in the offer and uptake of pulmonary rehabilitation. And in North Central London, there are many pathways and there are many cohorts of disadvantaged groups that we're looking at. One of those groups was different cultural and ethnicity that we wanted to look at. In Camden, there's a really rich and diverse population, both socioeconomically and culturally, often going hand in hand. And what we used initially was local knowledge, and then we referred to ICB data to look at how many patients met the criteria for referral into pulmonary rehab, and then how many actually were referred, and following on from that, how well did they engage. We identified 3 groups. That was the white Irish, black African, and the Bangladeshi populations. And what I'm talking about today is just the Bangladeshi and the black African. So what we found was, out of 64 patients who were eligible, according to GP records, for referral into pulmonary rehab, only 5 of those 5 patients were referred in the year 23-24. And of those, there were no completers, and they were dropped out at different stages in the process, some for musculoskeletal problems, but yeah, so we've got that information. So the aim of what we wanted to do is, we wanted to work with trusted partners. With health inequalities, trust is the key word that comes up all the time, and we wanted to hear as many voices as possible from marginalised groups. And we wanted to identify what was important to them and what a culturally sensitive programme might look like for them. And all of this was with a view to increasing their willingness to be referred into PR, and then increase the likelihood of them engaging once they were. So the method that we used was to set up 3 focus groups, and we worked in collaboration with local charitable organisations. They were extremely enthusiastic. And our first step was to meet with them and explain what we were trying to look at and what pulmonary rehab was. They then kind of did the legwork. We provided the promotional information in different languages, but they publicised it, and it was publicised for anyone with of interest because of COPD or asthma, but there were no exclusion criteria, all adults. And we offered incentives in the way of food and a £5 supermarket voucher, and we had translators there on the day. And that was all on the advice of the charitable organisations. So in the results, we met with 52 patients, which we were really pleased with, in just 3 focus groups. 65% of those who we met with came from the Bangladeshi population, and 33% from the Black Africans. So we were quite pleased that we seemed to have targeted those we wanted to hear from. I'm not going to spend much time on the next slide, because the point of the presentation is more about the collaboration rather than the findings that we had. But some of the findings pretty expected, but we did find some quite interesting things that we didn't expect in terms of attitudes to exercise, and what was important to these groups. So in conclusion, if you want to listen to multiple voices from marginalised communities, I think be prepared to work across different agencies with trusted people and organisations. Don't purely stick to healthcare. It's not just about translation, it's about them trusting the people who they are opening up to and sharing their knowledge with. And then obviously the hardest part now is taking this forward and then training staff and re-evaluating in 6 months' time what impact we've had. Okay, thank you.
Thank you, Jane. Okay, so can we welcome our next speaker is Ross Whelan from Kingston Hospital NHS Foundation Trust.
Hi everyone, my name is Ross, one of the respiratory physios from Kingston Hospital. So I'm going to be talking mainly about the management of asthma in a virtual ward setting. So Kingston Richmond Virtual Ward was set up in 2022 and is based in the acute hospital run by the acute clinicians. It's kind of speciality-led care given to patients. There's a whole kind of wide range of specialities, but this is focusing on respiratory. And it's obviously respiratory infections being kind of a leading cause of the clinical burden kind of for the NHS. And the virtual ward was set up at the beginning of 2022, kind of based on the NHS England mandate. Kind of all boroughs should kind of open a virtual ward, obviously to try and ease the pressures that the hospitals are facing, improving flows through the hospital. And we are kind of presenting data based on patients with acute asthma exacerbations on the virtual ward. So virtual ward admissions from January 2022 to December 2023 were examined kind of retrospectively to have a look at the impact we were having with these patients. 125 patients were admitted to the virtual ward with asthma being their leading cause for admission to hospital. And they had to meet a very specific inclusion criteria to be kind of eligible for our care. So it had to be on an improving trajectory. So whilst they were in hospital, if they were kind of worsening, they wouldn't be suitable for us. They had to be improving whilst they were in hospital. They couldn't have had any previous admissions to intensive care secondary to their asthma. They couldn't have any kind of VTE or sepsis that were driving their condition, and no kind of severe or poorly controlled asthma. And that's just based on the kind of mild, intermittent, mild persistent, moderate and severe classification. And our electronic clinical records were used to collect kind of the demographics, severity of their asthma, along with their length of stay in hospital and length of stay on the virtual ward, as well as their 30 and 90-day outcomes. So of the 125 patients that we took, average age was 58, but we had people as young as 19, and we had one patient who was 99 years old. Majority of these patients female, so 78%, with 22% of them being male. Some of them obviously may have had viral causes for their asthma exacerbations, with 2% being driven by COVID, 11% driven by flu, with the remainder being negative. In terms of their exacerbation severity, that's based on kind of their peak flows on admission to hospital, with majority of them being kind of mild, some being moderate, and in very kind of rare cases having kind of a severe exacerbation. So peak flows being much less than what they would be on a normal day for them. Length of stay in Kingston Hospital was kind of an average of 3.79 days, and length of stay on the virtual ward was kind of creeping to 10 days. And as you can see on the two graphs at the bottom, majority of our patients were taken within 1 to 5 days of their admission to hospital, with kind of 46 of those patients being taken within 48 hours of their admission. So really trying to catch these patients early to prevent them having to be admitted into an acute ward and continue their stay prior. So quite a lot of text there, sorry. All 125 patients received continuous monitoring. So that's 24 hours a day, 7 days a week, with 15 patients having that as their kind of only treatment process. A lot of patients were treated with nebulizers along with oxygen. And there were 64 patients who had an acute intervention from virtual ward staff, such as kind of point of care testing, repeat bloods, alteration, adaptations to their medications. Every patient received an asthma management plan, kind of an asthma bundle prior to them being admitted to the ward. And of the 125 patients, 13 of them were admitted at 30 days after their discharge, with a further 7 at 90 days. And of those 20 patients, only 10 were admitted with another exacerbation of their asthma, and which then kind of led them come to hospital. And 7 of those 20 patients were escalated directly from the virtual ward into hospital. So kind of by doing this, we've kind of shown that although asthma is quite high risk, it is an effective condition that can be treated well in the virtual ward setting. And that the impact of virtual ward care, particularly in the health promotion aspect of it, is kind of showing that it's an effective use of the virtual ward. Thank you very much.
Thanks, Ross. So now for our final speaker, can I welcome Susan Young from Nyron, is that how that's? Yeah, nearly. And Ivan Bevan, University Health Board. Thank you.
Okay, so yeah, thank you very much for staying through to the last rapid fire presentation of this session. It's one that hopefully will require very low cognitive bandwidth, so just bear with me. It's a very simple presentation compared to some of the other fantastic research that's been happening. So my name's Sue Young. I'm a cardiac rehab physiotherapist from South Wales, but I'm also co-chair for the ACPICR, which is the professional network for physiotherapists working in cardiac rehab. And I'm going to present today some work that we've done exploring the current UK provision of physiotherapy student placements and early physiotherapy career workforce opportunities within cardiovascular rehab. And I'd just like to acknowledge some of my other ACPICR colleagues who worked on this work stream with me, and in particular Helen Alexander, who designed the survey and analysed the results. I'm just presenting it today. So for anyone who doesn't know, cardiovascular rehab is an evidence-based outpatient rehabilitation programme for individuals living with cardiovascular disease. It's got a robust evidence base, and physiotherapists are absolutely integral to the MDT delivering this intervention. But despite the robust evidence base and the fact that physiotherapists are key in delivering cardiovascular rehab, we're increasingly getting concerns from our members regarding difficulties in recruiting physiotherapists into the specialty. Retention doesn't seem to be an issue. Physiotherapists that work in cardiac rehab tend to stay there. But once those physiotherapists retire, it's very difficult to recruit physios into the specialty. So we wanted to understand this a little bit better and get a feel for what the current UK provision of cardiac rehab physiotherapy work experience and pre-registration student placements is, because we know that early exposure to a specialty is absolutely fundamental in physiotherapists' career direction, future career direction. We wanted to understand what the early career workforce opportunities are in cardiovascular rehab, i.e. Band 5 rotational posts. And we also wanted to understand whether cardiac rehab physiotherapists are involved in delivering education about cardiac rehab at undergraduate level in universities. So we designed a survey which we shared with our members by email and social media, and we included specific questions to explore what the current provision of work experience and pre-reg student placements is in cardiac rehab, what the perceived benefits and barriers are to providing these placements, what the current provision of Band 5 posts are within cardiac rehab within the UK, and how many of our members contribute to formal education delivery in universities. And we also wanted to scope whether there was any interest in us as a professional network developing some resources to support our members. So 27 centres from across the UK completed the survey, and this was in the summer months of 2023. And in terms of work experience and student placements, the results were really positive, with most services supporting these kind of placements. And our members very much recognise what the benefits are of having students on placement, in that it exposes students to a specialty which then may trigger their interest in working in the specialty in the future. And they also recognise the wider benefits in terms of promoting learning within the team and helping members of the service to develop leadership skills. But even though the provision of student placements was good, there was still nevertheless a demand for us to produce some resources to support student placements. And we think this is because many physiotherapists working in cardiovascular rehab are part-time, so supporting a full-time student placement can often be quite difficult. So to have some resources that might supplement a placement was felt to be a useful thing. However, we found that very few physiotherapists actually lecture on the topic of cardiovascular rehab at undergraduate level. And in terms of early career workforce opportunities, there are actually very few services that provide Band 5 posts within cardiac rehab. So only 37% of services actually have Band 5 therapists working within their service. And this was a mixture of rotational Band 5, static Band 5, and Band 5 positions that are shared with another service. But the vast majority of services didn't have Band 5 physiotherapists working within their service. So just in conclusion, so the current UK provision of work experience opportunities and pre-registration student placements in cardiovascular rehab is good. However, few cardiac rehab physiotherapists are involved in formal education delivery, and many services do not have early career physiotherapists working in their service, which is a potential threat to the future cardiovascular rehab physiotherapy workforce. And ACPICR are now in the process of developing resources to support both cardiovascular rehab physiotherapy student placements and formal education delivery. Thank you very much.
Thank you, Sue, and thank you again to all our presenters there. Some great work being going on. Okay, so now we're going to open up for questions in the room and to any delegates online. So if you could just raise your hand and you'll get the mic either passed or thrown to you.
Thank you. My question is for Sally Singh. Sally, personalised exercise programs, most people would agree it's really important for effectiveness and also for adherence. And but often it's really poorly described in research studies. And I was wondering if you could tell us a little bit about how you're going to personalise the exercise programs and if you're going to measure adherence beyond attendance at the programs.
So that's two big questions in one, really, isn't it? So the way we personalise exercise is to individually prescribe and progress it. And most of the guidance is around 70% of peak VO2. Now, we don't do a full CPET on everybody that comes through the trial because that's not feasible or something that you would all naturally do in a clinical service. So we use the incremental shuttle walking test that we know in a wide range of long-term conditions has a strong relationship with peak VO2. So we would use that incremental test to prescribe exercise broadly using the FIT principles. So we have intensity, time and type by using the test, and then we just prescribe frequency on top of that. Adherence is a really interesting question. And I think we are all being increasingly challenged by that concept with the advent of digital and home-based interventions, because very traditionally we charted adherence by saying, oh, people came to the hospital 3 times a week and thinking that was all great and marvelous. I think there are some more subtle ways of looking at adherence in terms of exercise behaviors by using physical activity monitors. But I think you have to be careful what you wish for with a physical activity monitor. So I think sometimes we conflate physical activity with exercise behaviors. So they are challenging. So I think that if you're going to use an activity monitor, you have to make sure you understand what you're measuring, because I think otherwise you may get some surprises if you analyze it very crudely. So I think there are challenges around that. In terms of digital interventions, people monitor adherence by the number of times people log on. Well, you know, I don't really know what that means in a way. So I think adherence is very, very difficult. In terms of the national audit, I'm the lead for the National Pulmonary Rehab Audit. And we catalogue the number of sessions because we know in a supervised programme how many times people should attend in terms of what's described in the literature. There's not a clear dose response to that, as you might imagine. So we've never landed on you have to come for X sessions and therefore you are a completer or you've adhered. And I think it's becoming muddier with all these home-based programs. So that's not a very good answer, is it? But hopefully a reasonable explanation of where we think we are.
Thank you. Any other questions in the room?
A question for Jane around working with the charities in the community. You talked about the importance of the charities and kind of linking you with the marginalised communities, but the data you showed is the referrals in the first place were really low from the clinicians. Do you see any role in those charities actually working with the health professionals themselves?
Yeah. Is that on? Yeah. I think the the word of caution, I suppose, is that there are a lot of charities out there, so it's identifying which ones are going to have the greatest impact. But yeah, I see no reason why not. I think the next stage is to share the learning with the referrers, if you like, from the work that we've done, and then think about raising the profile of the charities within primary care. I just think there is a risk of, I think in primary care, time is so tight. There's so much happening, isn't there? It's what would that look like? That might be something to think about, but some sort of promotional material, possibly. Yeah, but I think primary care is certainly pushed to the limit. So I think what we really wanted to do was to get some key selling points for primary care and referrers to use. So for instance, one of the things that came up really strongly from the Bangladeshi community was around confidentiality. So if that's one small thing that when you're talking to a patient about referring them in, if you can offer that reassurance, then I think hopefully that will have some sort of impact, because that was a very real concern within a small community. If you're seen to be going to being assessed in a group, people will know you smoke, and they'll know that you've got some of your medical history unless you reassure patients. So I think the first step was to take the findings to referrers, but yeah. Thank you.
Can I ask a question, being I'm sort of standing next to the microphone? I think the work you've done around the health inequalities is really important, and we have a number of PhD fellows in Leicester looking at health inequalities. I guess there's a couple of things. One is we're absolutely shocking at recording them. Secondly, we're really bad at asking people what their ethnicity is, sexual identity, etc. So I don't know how we overcome that. And then being slight devil's advocate, when I did the maths on your population that attended rehab, it was about 6%, which is shockingly low, but it's double the white British. So I just wonder how you compared your data to the white British population, and what you can learn from, reverse engineer and look at the white British population that don't come to rehab as well.
I would agree that certainly I think the referrals are better when we looked at it from the data that we had, the referrals in were better for the white British, but the adherence, but the adherence is poor, really poor. So yeah, it is a factor, I think, isn't it? I think it is everywhere.
Any more questions online or in the room?
So this is a question for the first speaker, and also I think you who talked about the cardiac rehab, cardiovascular population, the younger band 5 physios, and also for Sally, because what you described was cardiac rehab for over 80s, but really impacting people's frailty, reducing falls, etc. And for me, this is about moving towards this more kind of multi-morbid, multi-benefit impact of rehab. And I'm interested in how this is going to emerge over the next few years, particularly supported by the kind of research that Sally is doing and leading. But I wonder if you would be able to comment on that. So moving towards more of a multi-morbid rehab offer.
So we're currently developing cardiac rehabilitation intervention for that population using the Keep Up app. So we're hoping that's going to build the strength, and it can incorporate people who do have more, like who are multi-morbid, and it'll cover them and the cardiac patients.
Yeah, can I just add to that? Is this working okay? Yeah. I think as physiotherapists working in cardiovascular rehab, pulmonary rehab, we embrace this concept of, multi-morbid rehab, and we're doing it already. As Sally said, most of our patients have comorbidities, and we know that our exercise interventions are benefiting those comorbidities as well as their index condition. But I think sort of what's happening alongside that is the specialties are developing as well. So, for example, with cardiovascular rehab where I work, I quite frequently get told by the nurses it's not just about the exercise, and it isn't. There's a big proportion of medical risk factor management that's happening, sort of health behaviour change that's specific to cardiac conditions as well. So it's making sure that the two things align really, so the patient's getting the rehab that best suits their needs, I guess. I don't know if Sally has anything to add to that.
No, I was just, I guess, being devil's advocate in a way. Thinking about the workforce and some of the challenges we've had. So I spend my whole life looking after people with breathing problems and completely comfortable with that. Whereas colleagues in cardiac rehab get really anxious about people getting breathless, and vice versa. Respiratory physios get anxious about people that have just, had a heart attack and they think they're going to keel over. So it is interesting that people, become siloed and anxious about proactively managing other conditions. Of course, people come with other conditions, but we tend to park it a little bit. And I think there's something around workforce training that we pull back from being super specialist, but also learn to embrace all of these other long-term conditions. I was in a room with a patient last week, and she was recounting that when she did an exercise test, the main reason she couldn't continue walking was because of a painful knee. But actually she was in pulmonary rehab. So it was a slight inconvenient truth in a way that it wasn't the breathing that had caused the problem. And of course the physio said, oh yes, well, we adapt the exercise. But they didn't acknowledge or help her manage her pain or her sleep that she was being disturbed by. So I think there's, when you really talk to people, there are wider issues that go beyond our conventional pulmonary rehab or cardiac rehab. And I think as physios, we are absolutely well placed with that skill set to manage these people, and we should celebrate that and be more open about it, because I think multimorbidity rehabilitation are huge on the government's agenda at the moment. And I think that we should, really push the fact that we are the group of people that can do that.
Yeah, I all agree with that, Sally. I suppose what you're raising is the workforce challenge, the demand from the population, the absolute imperative to look at a broader model of rehabilitation that includes all these interventions that you've described that will enable the population. And it's really exciting to hear these initiatives being talked about like this, because it aligns with what the Chief Medical Officer says as well about the move towards more people retaining those broader skills in order to support people with multimorbidity, and how we really do democratize and widen access to and participation in rehabilitation. Sorry, slipping through.
We might have time for one more question if anyone's got anything. No. Great, thank you. So we'll draw this session to an end now. Thank you, everyone. And if we can just give all our speakers another round of applause for all the great work. In my eagerness to get into this session, I omitted to introduce myself. So I just wanted to say I'm Alex Spears. I'm the Divisional Director of HPs at Liverpool University Hospitals, but I'm also Vice Chair of your CSP Council. So please, if you have any questions or any time today and you want to come in and have a chat about anything in particular, just come and give me a shout. Thank you.